So unlike the textbooks, the anatomy can range widely in clinical practice, and this is especially true for the Circle of Willis, where the anatomic variant is the rule, not the exception. Therefore, I think it's worthwhile to understand a few of these common variants to avoid confusion, which is especially helpful when you're looking at the CTA of a patient presenting with an acute stroke where time is really not in your favor. Before you can understand these anatomic variants, it is crucial to understand the anatomy. So let's begin to first look in detail at the textbook anatomy of the cervical arteries and the Circle of Willis, and then we will look at the common anatomic variants that you may encounter. Before we start, please note that this is by no means a complete list of all branches and all anatomic variants, but nonetheless, I think this covers pretty well everything you may need to know as a student. The Circle of Willis can be divided into the anterior and posterior circulation. The anterior circulation is supplied by the internal carotid arteries, and the posterior circulation by the vertebral arteries. The anterior and posterior communicating arteries connect these different parts of the Circle of Willis, ultimately forming, as the name implies, a complete circle. Let's begin with the anterior circulation, starting from the aortic arch. The right main common carotid artery comes off the brachiocephalic artery, which is one of the three main branches of the aortic arch. The left common carotid artery comes directly from the aortic arch. As you follow the common carotid artery cranially, it bifurcates into the internal and external carotid artery. The internal carotid artery, or ICA, tends to course more laterally and posterior, while the external carotid artery courses more medially and anteriorly. However, the best way to tell them apart is simply to check for any branches. The ICA has no branches in the neck or the cervical segment, so we know that this is the ICA. Numerous classification systems are in place for the ICA segments, and we'll be using the Guypo and Rotons classification, which is commonly used. Once the ICA courses more cranially, it reaches the carotid canal, which marks the patellar segment where the artery courses in a horizontal manner. From there, the artery reaches the cavernous sinus, becoming the cavernous segment. Here, it begins to form the carotid siphon, which is a U or S-shaped part of the ICA, which is often used as a radiological landmark in digital subtraction angiography. Once the artery exits the sinus near the anterior clinoidal process, it becomes the supraclinoid portion, which can be subdivided into three parts. A very important feature here is the ophthalmic artery, where the origin is just above the dural ring. The ophthalmic artery is therefore commonly used to divide aneurysm into intra- and extradural aneurysm, where the latter does not typically cause subarachnoidal hemorrhage upon rupture. Now, for the final part of the ICA, it bifurcates into the anterior cerebral artery, or ACA, and the middle cerebral artery, the MCA. The posterior communicating artery also branches off the ICA, connecting the anterior and posterior circulations. The anterior and middle cerebral arteries are just like the ICA, subdivided into segments. So beginning with the letter 1, where the larger number indicates a more distal segment. A first segment of the MCA is the M1 segment, which gives off important perforators supplying the deep brain structures. Further distally, the MCA branches and gives off the M2 branches. Some advocate that anatomic landmark rather than bifurcation marks the beginning of the M2 segment, but for simplicity, just think that every time the artery branches, it gives off a smaller branch with a higher number. So the M1 branch will branch into the M2 segments, and the M2 segment will branch into M3 segments, and so forth. For the anterior cerebral artery, however, the A1 segment courses towards the anterior communicating artery, which connects both anterior circulations. The anterior communicating artery also marks the A1 segment from the A2 segment of the ACA. The posterior circulation is supplied by the vertebral arteries. Both vertebral arteries are the first branch from the subclavian artery. Just like the ICA, the vertebral artery can be subdivided into segments. The V1 segment, or the first segment, courses towards the transverse foramen of the C6 vertebrae. Once it reaches the transverse foramen of the C6, it courses from the C6 to the C2 vertebrae within the foramina. From this point, it becomes the V3 segment, where it courses laterally and up and through the transverse foramen of the C1. Once it exits the foramen, it courses posteriorly over the C1 arch and then intradurally, where it becomes the V4 segment. The V4 segment then continues and gives off the posterior inferior cerebellar artery and the anterior spinal artery. just before it joins the contralateral vertebral artery forming the basal artery. The basal artery gives off a pair of the anterior inferior cerebral arteries. As the basal artery runs cranially, it gives off small perforators, and then just before it bifurcates, it gives off a pair of the superior cerebral arteries. The basal artery then terminates into the posterior cerebral arteries, which can be divided into the P1 and P2 segments. Similar to the ACA, the posterior communicating artery divides the P1 and P2 segments. I think we covered the textbook anatomy now pretty well, and we are ready to look at some anatomic variants. And we'll begin with the vertebral arteries. Quite commonly, people have one side more dominant than the other one. And it can be quite tricky if you suspect a vertebral artery dissection. 2 tips here. First, always look for a prior study. And then second, look at the transverse foramen. Does the foramen match the artery? This means that if the foramen is of a smaller caliber, just like the artery, then it's likely a hypoplastic anatomic variant. One other feature of hypoplastic vertebral artery, sometimes the hypoplastic vertebral artery terminates as the PICA, which means that the dominant vertebral artery is the only one supplying the basilar artery. Now let's look at the basilar artery. I rarely encounter basilar artery variants, but I think it's worthwhile to know about the most common carotid basilar anastomose. Although these are rare, the most common type of variant is the persistent primitive trigeminal artery. It's an important supply for the basilar artery in utero, and it may persist into adult life. You may see a connection between the cavernous segment of the ICA and the basilar artery, and as the name implies, the vessel courses along the trigeminal nerve, and rarely it may cause trigeminal neuralgia. Anatomic variants are very common in the PCA. One common variant is the fetal type PCA. The P1 segment is either hypoplastic or absent, and the ipsilateral posterior communicating artery is supplying the posterior circulation. The PCOM is therefore a larger caliber than usually, and if you need the reference, you can look at the contralateral site, given that the variant is not bilateral. Variants in the anterior cerebral artery are also quite common. The A1 segment is commonly hypoplastic or absent. Rarely, you may also see that both A2 segments form a single artery called the azygos ACA. This is however often termed as an anomaly, as this variant correlates with increased prevalence of aneurysm. This however is usually of no clinical significance when encountered incidentally. One other rare, but I think quite important variant to know, is the artery of Percheron. This is a variant where the blood supply of the thalamus, which is usually supplied by the paramedian arteries, arises from one PCA instead of being bilateral. This means that a single vessel occlusion can cause bilateral thalamic infarction, and it's a good differential to keep in mind in cases of a bithalamic lesion. Now I think we covered pretty well the textbook anatomy and some common variants and some rare that you may encounter. And I would like to end with a few tips that I found very helpful. The first tip is always, and I mean this especially for CTAs, use MIP series. It gives you a much better overview of the anatomy and makes it much easier to search for any abnormality. For intracranial arteries, I have found that 4 to 5 mm slices usually work quite well. In cases of a stroke, you can also use 20 mm MIP slices, which can function as a poor man perfusion, given that you don't have a CT perfusion scan. And lastly, if you are in doubt, you can correlate the CTA with a native CT. This may work in cases where you're not sure if you have an occlusive vessel or simply there is no vessel there. So comparing the native CT may help you see if there is in fact a vessel there, which may not be filled with contrast. Now, as always, thanks for watching. Subscribe if you liked more content and feel free to check the Instagram page as well.